My name is Dr. Valerie Abel, and I am a clinical psychologist and a neuropsychologist, and I have a specialty area working with older adults, which is called the field of geropsychology. I currently work at the VA New York Harbor Healthcare Center. That's the VA Medical Center in Brooklyn. And I help run a fellowship training program, training psychologists who want to get experience in working with older adults. So we bring psychologists in, and we work in various settings in the hospital setting with older adults. We work in oncology, on an oncology unit, in geriatric primary care, and in the nursing home setting. So it's a number of different areas where older adults come into the medical setting. I also have a private practice where I see older adults in the community. So in that situation, I'm seeing older adults who are usually not necessarily interacting in the same way with the medical setting, but are living in the community and are often coming in for other issues.
Well, one of the things I'm curious about with the settings where you're talking about the 3 different settings where you are, I wonder if people think about psychologists when they talk about oncology kind of clinics. Can you talk about the different services that you provide across those settings?
Right, absolutely. Working in the VA setting actually it's really a great place to work, because the VA has done a lot of work over the last few years to really integrate psychologists into medical settings. So in situations where, we just had a speaker talk before at the Mind Body Health Fair about the importance of integrating psychological services and behavioral health into medical settings, and how it really doesn't happen a lot of times. So we have, over the last few years, really found a way to bring psychology in, for example, on the oncology unit, bring psychologists in as a part of the medical team. So where patients are met with by the medical team, the psychologist meets with every patient who comes into the oncology setting to address any kinds of behavioral health issues and emotional health issues. So obviously, when people are first receiving a diagnosis of cancer, a sort of life-threatening illness, there are often a lot of issues that come up around adjustment to dealing with that diagnosis, depression, anxiety, issues that come up around compliance with medical treatment that the medical team very often has a difficult time addressing. Being a neuropsychologist as well, and the fact that many of our patients that come into the setting are older patients who are severely medically ill, it's very important to have somebody who's able to address the cognitive piece of what's going on with patients, because very often that has a huge impact on the medical team's ability to communicate, to get a patient, again, to comply with particular medical treatments. So psychologist plays a very unique role in interacting with the patient as well as with family members, and integrating that with the medical team so that the patient gets the most appropriate, effective treatment possible. And there's a lot of research that shows how bringing those sort of services into these kinds of settings really benefits the patient, improves outcomes overall. Of course, on an oncology setting like that, we're also dealing with a lot of end-of-life issues. And psychologists have a big role in end-of-life issues, again, in working with patients and families, and in helping medical teams figure out how to work with somebody who may be assessing whether somebody is depressed, how well they're able to be participating in their end-of-life decision-making. So psychologists have very important roles in end-of-life in those types of situations.
Okay. How do you think, or do you think there are any, what do you think the major issues are facing psychologists who are working with the aging population?
Right. I think, unfortunately, there aren't enough people who are trained to work with older adults, and you know, I mean, I think everybody keeps hearing this, but people don't really realize our aging population is growing and expanding. And over the next 10 years, I mean, I'm forgetting what the numbers are, but as the baby boomers are now entering 65 and older, the aging population is becoming bigger and bigger. People are living longer with chronic illnesses, so there is just a huge demand for psychologists to be working with older adults. So I think access for older adults having access to mental and behavioral services by psychologists is really an issue. With issues in healthcare now, and reimbursements and Medicare issues, we find that it's difficult for a lot of psychologists to work as providers, to work as Medicare providers. So that that causes an access issue for people in the community who may be looking for a psychologist or accessing a psychologist who takes Medicare. I think another issue is that we're now moving in this direction, but I think it's been difficult, that we really need to be thinking much more, and we do a lot of this in the VA setting, and I've done a lot of talks about this, about integrating psychologists into settings, into medical settings where older adults are receiving treatment, because it's quite free. When we sort of work in a separate silo from the medical field, it's often it's difficult for older adults to access mental health and behavioral health treatment when it's separate from their medical treatment. A huge percentage of older adults actually get their mental and behavioral health needs met in the primary care setting, just because of the stigma of seeing a mental health provider, or because of just accessibility issues. So we really need to think about, there's a huge need to really integrate our services into medical settings. And with healthcare reform, that is a big aspect of of the National Healthcare Reform Bill, and the way things are sort of rolling out on the state level. There's a big focus on integrating behavioral health into medical health. So it's really, with the idea that it will really improve access, and I'm talking specifically for older adults, it will improve access, it will improve the quality of care, and ultimately we hope will really reduce costs of medical care, because we know how much integrating our services into overall health care really improves care and improves outcomes overall. So I think there's a number of issues sort of facing psychology and healthcare in general, which are being addressed with healthcare reform. So I think we're hopeful about the direction that things could go in.
Okay. And you've said that many older adults get their mental and behavioral health care in a location that's
right.
kind of co-located.
Right.
What have you found in terms of being able to collaborate with primary care providers?
Uh-huh.
Has that been a pretty receptive thing, pretty collaborative?
I think it depends. I think that if a psychologist in my situation, in my community, I've formed a relationship with a few primary care physicians right in my area, and our offices were located in the same neighborhood, and they would frequently make referrals of their patients to me. However, I find that even that sort of situation sometimes means that patients don't make it to their appointments. They don't make that sort of crossover. The way our medical system has been set up, it's made it very difficult for psychologists to actually form collaborative relationships with physicians where they really work in the same setting. I mean, I know that some people do work in a co-located setting, but there's been a lot of barriers for a psychologist in terms of billing issues and how to really work out the reimbursement issues in those sorts of settings. So we've really been struggling with how to really integrate in a way. So I think there's a lot of physicians, especially physicians that work with older adults, who really understand the need. When I said that many patients end up getting their mental and behavioral needs, healthcare needs met in the primary care physician's office, I meant by the primary care physician, which means writing a prescription, and not necessarily getting the sort of interventions that could really benefit them.
So, Dr. Abel, maybe you could talk a little bit about and I think that this is maybe across the board, where some people feel like the primary care physician or the provider is adequate and perhaps sufficient for behavioral health. It sounds like there's some of that going on in the aging population as well. Can you talk a little bit about the role a psychologist would play and the additional things that a psychologist can bring to the team?
Oh, absolutely. Right. When I said that a majority of patients, and it's actually not just with older adults, it's with a lot of patients, when I said they get their mental and behavioral health needs met by the primary care physician, I'm talking about that it's frequent that a primary care physician will prescribe a medication for depression, for example. We all know how quickly primary care visits happen, so primary care docs just really do not have the time to spend with a patient. They can write a prescription, but we know that mental and behavioral health needs really need more time. Psychologists are the doctoral level providers who can assess depression, anxiety, other mental health issues. We are the experts in behavioral and health and change, and helping people change some of their behaviors around medical issues that may be going on. And so we have the time to be able to assess and work with somebody over time. We also work in a scientifically based, using evidence-based treatments that have been shown to be able to treat these issues. I brought up cognitive issues before, so we are also the doctoral level providers that can assess cognition. So, you know, this comes up a lot with older adults, where there may be an issue of is this patient showing some cognitive decline? Is there a possible dementing process going on here? Is the patient not functioning memory-wise, or has showing some changes in terms of their thinking abilities because of depression or because of anxiety? And how do we intervene in that way? And how do we convey to the physician better ways to be able to work with a patient who maybe is experiencing some memory loss? So we just have we are really the experts in the mental and behavioral health issues that come up, where, yes, certainly, a physician may be able to prescribe a medication for depression. We are really the ones who are, trained in assessment and treatment of these issues.
With the older adult population, do you find particular mental or behavioral health issues more common or more commonly confused with each other when you have people come in and digging sort of into that investigative process? Right.
Well, again, I've been talking a lot about medical issues, so certainly a lot of older adults are dealing with health issues. But not everybody, right? We certainly come across patients who are, older adults who are fairly healthy. So very often we're dealing with sort of life transition issues that happen for people as they're aging. And we see people sort of across the board. People are many older. I mean, we're talking about older adults from the age of 65 and on. So we have many different age cohorts in that group. People in their 90s are dealing with very different issues than people in their 60s, and come from very different places. So we're often psychologically and emotionally dealing with transition stages in people's lives. For the older adults, we're dealing with issues of retirement. Children leave, the empty nest syndrome, just changes in sort of family structure. And as older adults get older, we're dealing with issues of loss. Loss of friends, loss of family, to death, to illness, coping with loved ones who maybe are struggling with medical issues, dementia, how families deal with dementia when there's an individual with the dementing process. changes in their community, loss of their social support system, so a lot of issues around loss. However, I have to say that, one of the reasons that I really loved when I first started working with older adults, and my first experience in working with older adults was in nursing home settings with patients who were really sick and frail often, and often had very little left in their lives. And I was so struck by how much the majority of people still found something very valuable about their life and had a reason to live another day in some situations that I initially thought, how could anybody be facing this? So I'm continuing, even though, we often think of aging having to do with loss, loss and sort of negative things that happen in this transition in our life. I'm really struck by the resilience of older adults and the many, many positive things that we hear about and ways that people really cope and, again, are really resilient to some of the difficult things that can happen at the end of life, and that there are many wonderful things that you hear about happening in these transitions.
I have an interesting question, or maybe a little bit along different lines. How do what psychologists actually do differ from what people think psychologists do?
Well, I think it's important for the public to understand that, we are a talking profession. I think we're known as doctors that people sit down and talk to. But I think it's really important for, nowadays there's a number of different professions and some master's level professions who are also fall into the sort of general category of therapists and sort of the talking professionals. So I think it's very important for people to understand that psychologists are trained in assessment and evidence-based treatments and interventions. So we work from a scientific perspective, and our assessment skills, really being able to assess a situation, assess a patient's situation. We use a lot of different evidence-based tools, assessment tools, that then inform our treatments. So I think it's important, it's not important as when somebody comes to sit down and talk to a psychologist. They're there to get the help that they need, but I think it is important for people to understand that psychologists are doctorally trained professionals who work from a scientific evidence-based perspective.
Okay, so you've mentioned a little bit about integrative care and those kinds of things. Can you give me an example of what integrated care would look like?
Right. So in the VA setting where I work, we work in a very integrated manner in the geriatric primary care clinic. So patients are coming into that clinic for their regularly scheduled doctor's visits, and the psychologist and the neuropsychologist sitting in a room in the same hall of offices where the medical doctors are, and the medical doctor will see the patient, and we've worked together collaboratively enough that they are sort of pretty well educated about how to screen for cognitive problems, again, kind of memory problems or any kinds of thinking problems that come up with older adults. They also are pretty well educated now about being able to screen for depression and things like that, and they certainly are aware when their patients are non-compliant with treatment. So they will, after they see the patient, they'll be able to say to the patient, to the older adult, let me just walk you over here. I want you to meet Dr. Abel, who's the psychologist who works with us on our team. And I will be able to, we set it up where I am available to meet with the patient, usually for a short period of time, but be able to kind of quickly assess a situation and be able to educate a patient about what we may be able to offer and make it part of, the whole team is able to present to a patient that we take these issues very important. We consider these very important in terms of your health care overall. And we're all in the same ballpark, and we're all here to help address these issues. So it means that there's not the sort of stigma that somebody may feel if their physician says to them, I want you to go see the psychologist, and call and make an appointment and see them in this other building in a couple of weeks. It makes it sort of normative. We see a lot of patients in that way, and we have a lot to offer in terms of improving health care overall in some of the ways that we've talked about before. So it allows some of our older adult patients who, it's a big deal for them to get into the medical center to come for their appointments. It allows them to see the psychologist in the same appointment. It's not stressful to them in terms of thinking that they have to go, even if they are in the hospital and they're sent to another floor somewhere. Very often we would miss people that way. So it allows the message to really be to the patient that your mental, behavioral health needs, your emotional needs, your ability to comply, to deal with some of the health issues you're dealing with is of interest to the medical team overall. So we find that we really, we are able to access patients a lot more easily, and we really are able to use our services in a way that's really accessible to patients in that way.
So finally, maybe there are some things that other issues that you think are important in terms of working with this population?
Right. Well, one of the things that comes to mind that I know comes up for people a lot when we think about aging and older adults is Alzheimer's disease and dementia. Again, as our population ages, we're seeing a growing incidence of dementia and Alzheimer's disease. Primarily because people are living longer, and the older one gets, the higher risk you are at for developing dementia. So dementia and Alzheimer's disease has become a huge public health issue with costs a lot of money. It's a big expense in our healthcare system. And unfortunately, as advanced as our medical field is, we do not yet have a cure, for a biological cure, a medical cure for dementia. Although there's a lot of money being pumped into research for that, and I'm hopeful that in the near future we will certainly be making advances in that direction. So the primary interventions that we can make that improve the course of dementia and improve the outcome of individuals and families who are dealing with dementia are behavioral and mental health focused. So the research that we do have that looks at slowing down decline all have to do with kind of behavioral health changes. The ways that we promote sort of healthy aging are all, there's many kinds of protective factors against cognitive decline, and these are prime areas that psychologists work in. So really the focus in, again, managing dementia, again, promoting protective factors to reduce the incidence of dementia, as well as intervening when dementia is already happening, are all behaviorally oriented situations. So psychologists working in nursing home settings, helping staff manage some of the behavioral issues associated with dementia. These are all really important areas, and areas that we have to support in funding, because this is really where the research is right now, and we have the most to offer really in this situation, and hopefully our medical field will catch up eventually, and we will really be able to prevent or cure dementia, but we're not at that stage yet.